So don't expect this challenge that appears in this question from a question bank that they are using abbreviations. It's not the usual in English, but it means premature atrial contraction, in contrast with premature ventricular contraction. So are going to be narrow QRS uh, um, contractions without a P wave, probably coming before time, so premature, but are narrow QRS. That's why they say that it's an atrial contraction. It's not a ventricular contraction. So maybe there is one of you that is not understanding what I'm saying. When you have premature contraction, you have a base rhythm that is normal, that has P wave, QRS, yes, has P wave, QRS, okay? It's not perfect because I'm doing that with the mouse, okay? So, but try to imagine that I'm trying to represent a normal, a perfect, okay, a rhythm. E, QRS, QRS, okay, QRS, etc. So notice that has P, notice that the QRS are narrow, and notice that the distance between the R and the R's, the R intervals, are constants, are the same distance that I'm trying to represent. And then suddenly comes a QRS, a QRS now that is before time. So you have a QRS that is before time. So notice that this QRS that I'm drawing here has not P wave before, is very, mute your microphone, is very approximate to the previous QRS, but is narrow, so it's very similar to the previous QRS. So I say that it is premature, okay? It is premature. After a brief interval, the normal rhythm restarts, no? Restart. Sorry, shouldn't be so wide, it should be narrower, okay? But the normal rhythm restart, okay? The normal rhythm, the base rhythm restart. So it is an isolated event, this beat that is coming before time, but in this case has no P wave, but is narrow. So I say that this is a premature atrial contraction because the narrow QRS tell me that it's a supraventricular or atrial origin or source of this abnormal event. If this premature event were wider, the QRS were wider, were wider and very different from the just a second, trying to make it okay better. So let me erase, okay, the previous QRS. Okay, so now I'm drawing a very wide, QRS that is becoming before time, but is wide. The QRS is wide. Then I can say, oh, this is a premature ventricular contraction. So this is the way, just in case you have in any moment, okay, an EKG that you need to identify either one, the way that you can identify why is premature, because it's an isolated event, an isolated beat that comes before time. So notice that it's coming too narrow, not too narrow, too proximate to the previous. So it's before time, should come later. And if it is narrow, is atrial or supraventricular. And if it is wide and bizarre, is probably ventricular. This is not a rule that can be applied in the 100% of the cases, but can be applied, let's see, in the 99% of the cases, and it's a rule that could be useful for a nurse to differentiate ventricular versus atrials bits. The ventriculars are wide QRS, while the atrials are narrow and very similar to the previous QRS, okay? So just in case. The premature atrial contraction have less, let's see, less, how you could say it, risk Yes, less risk than the ventricular. The PVCs in ischemic clients or the ventricular can trigger ventricular tachycardia and ventricular fibrillation, while the premature atrial contraction usually don't do that. Instead, they can precipitate supraventricular tachycardia or atrial fibrillation. Okay, is the representation. The big majority don't produce anything, so it's a risk. It's not an actual problem. It's a risk. It is worth a ventricular, and the client is not going to experience symptom because this is generally not perceived by the client. It's not an event that produces symptoms. Okay, so this is what I wanted to explain, so uh, you know what is a PAC and PVC, the difference between a PAC and PVC. Okay, so that's it. This the only purpose of this little clinical. Let me tend to erase that because I don't know why cannot use the eraser. I don't know. Okay, that's it. Okay, so let's return to our questions. The client is having PACs and EKG, has S1, has S2. Of course, it is a redundance. If the client is alive, must have S1 and S2. The only reason of not having S1 and S2 is because you are dead or you are in cardiac arrest. Okay, so has S1 S2. But the difference that what it makes special is that the client has S3. So you need to know that S3 in this kind of a scenario, okay, like the one that we are talking here, implies this kind of S3 implies heart failure. So you can conclude for test purposes that an adult client with previous on cardiac disease like this client having an S3, it is conclusive, is strongly orienting that the client is having heart failure. Heart failure. So this three is an auscultatory manifestation of an enlarged ventricle that is the condition that we observe in clients with heart failure. So we can conclude that this client is having heart failure with all the symptoms and the presence of S3. Client has weak peripheral pulses and cool extremities. Notice that having left heart failure, the cardiac output, I mean the amount of blood in milliliters that the left ventricle is pumping forward to the arteries is decreased. This could explain why the pulses are weak. And of course, if not enough warm blood is arriving to the extremities that are the most distal part of the body, the extremities are cool. Of course, in the test, you are not going to do so much uh, physiopathological analysis, but it's important when you study to understand that the clinical judgment questions are complex questions of very straightforward situations in which you need to know all the clues that the scenario is giving you. So you need to interpret everything to try to reach a conclusion and to avoid deviating to wrong conclusions. Deny chest pain. I insisted that since the beginning. It doesn't mean necessarily that the patient could not having cardiac ischemia, but at least it's less possible. Yes, it's true. There are clients that can have uh, myocardial infarction or angina without chest pain, but it's the exception of the rule. Trying to go in those clinical cases, not with the exception, trying to go with the rule, with the general. So don't overthink. So denying chest pain, the problem is not another myocardial infarction. The problem is that the previous myocardial infarction left the heart weak and large, and the patient is presenting heart failure. Tachypnea, which means that the patient is breathing faster than normal. A question, guys. I need you to answer this question. If this client with heart failure is having tachypnea, probably is because the amount of oxygen in the blood is decreased. That's why the client has tachypnea. So it's breathing faster than 20, yeah? It's probably breathing 28 times per minute. So has tachypnea, increased respiratory rate. Okay, and the trigger of this tachypnea is that the heart failure. I mean, the lungs are filled with liquid. The alveoli are filled with liquid, and for that reason, the gas exchange is impaired, and for that reason, the blood, the oxygen is lower than normal. These lower amount of oxygens arrive to the brain. Brain detects that the oxygen is low, and then orders the lungs to breathe faster. My question is, how is the CO2 of this client increase or decrease? Increase or
Increase.
decrease?
Increase.
Everybody agrees, no? Okay, I want you to know the following. When the respiratory rate is increased, so it's faster than normal, the CO2 decreases. Decreases. It's something that I need you to learn, because I discover that it's very frequent that nursing students don't understand this detail, and they don't answer correctly the questions in English when there are ABG questions. You need to understand there is an inverse correlation between the amount of CO2 in the blood, in the body of a person, and the respiratory rate. Any increase of the respiratory rate, I said this client is breathing 28 per minute, so has tachypnea, yes? Has, increased respiratory rate, must produce a drop in the amount of carbon dioxide that is in the body, in the blood of the person, because carbon dioxide is expelled, is excreted, is eliminated through the respiration. If the respiration rate increases, more than normal CO2 is eliminated, and then the amount of CO2 left in the body decreases. When the CO2 increases, when is that the CO2 increases? When the respiratory rate
Slow.
decreases. For example, you have a patient with COPD. A patient with COPD is a patient with a condition that produces a diffuse disseminated obstruction. That's why it's called obstructed pulmonary disease. Obstruction in the bronchi, in the pipes through which the air moves in and out. And precisely because it's so difficult to move the air in, but then it's even more difficult to move the air the air out. The client takes longer in inspiration and expiration, and for that reason, the respiratory rate decreases because cannot breathe fast. It's going to take a long time to breathe in, breathe in, breathe in, breathe in, because it's very narrow. And even more time breathing out, breathing out, breathing out, breathing out, breathing out, breathing out, breathing out. So each respiratory cycle is going to be very, very prolonged. And as a consequence, the client has hypoventilation.
Professor,
In
I have a
which,
question.
yes, go ahead.
And because I was the one that said that increase, uh, because I've seen some questions, but now you're responding in regards to COPD. Does this works the same in COPD and heart failure, or COPD works different?
Is different
Okay.
because in heart failure, you don't have obstruction in the airway. The
Oh, that's right.
airways are wide, are open.
Got it. Got
There
it.
is not difficulty in moving the air in and out. The
Got it.
problem is that in the alveoli, those bubbles at the end of the bronchi are filled with water, and the water that is inside the alveoli impede or difficult the entrance in the blood vessel. You know, there is a blood vessel that comes without without oxygen, and after the gas exchange live with oxygen. No, so this gas exchange is impede, and the gas that has most difficulty diffusing in presence of liquid is the oxygen, not the CO2. The CO2 is 40 times more soluble in water than the oxygen. So it's 40 times more soluble than the oxygen. It's possible for the CO2 to live, but not for the oxygen to enter. You understand? And for that reason, there is a drop of the oxygen, and the drop of the oxygen makes the brain enters in panic. Brain enters in panic when the oxygen is low, because the number one need of a human being in the Maslow priorities that you know is oxygenation, more than food, more than water, more than warmth, more than money, more than sex, more than the priority to human beings. Number one is breathing. And you know that without oxygen, we last only 3 to 5 minutes. Yes. Okay. So this is must be understanding. This is the difference. So when also you have decrease respiratory rate and retention of CO2, and overdose of morphine or fentanyl. Okay, what happens there? The respiratory center in the brain stem, is suppressed by the opioids, and then there is not electrical stimulus, there is not nerve stimulus for breathing. So now the patient is going to arrive with the respiration 6 respiration per minute. This is another example in which the respiratory rate decreases, and then you expect to have the CO2 increase. What other example? Because I want you to have those examples because are in NCLEX. You have a patient with Guillain-Barré, Guillain-Barré, and the Guillain-Barré has paralyzed all those nerves that participate in the movement of the muscles that make you move the air in and out, the muscle that participates in the respiration. So the poor client is totally conscious, is aware, totally aware, but it cannot breathe, and is sadly cannot breathe, and because the patient is cannot breathe, is having a very low and very superficial respiratory rate, and then have increase of CO2. For example, a client that has an acute obstruction of the airway, suppose that is a hot dog. Okay, a hot dog, a piece of hot dog that gets stuck there in the airway, that is, by the way, so frequent, and pieces of meat, of beef, etc., can produce that. So the air, because the trachea is totally obstructed, cannot enter and leave. The client is hypoventilating. So in those cases, the CO2 increases. But what happens when the person has a panic attack? When the person is having a test and the first question, never heard about the first question. What happened? The student enters in a real panic attack, yeah, a psychological panic attack, without having any problem in the lungs or the heart. So now the client starts, I, I don't know this question. Help! Oh, Santa Barbara! Virgin Mary, help me! Okay, so the client start hyperventilating. It's a panic attack. So now you have an excessive, hyperventilation, and the client expels too much CO2. That's why they put in front of the nose and the mouth of the client a paper bag to return the CO2 to the client that is expelling too much oxygen. So please, I need you to understand there are diseases of the respiration in which the oxygen alone is low, but the CO2 is not high. So in those conditions in which you have low oxygen, but low CO2, so low oxygen and low CO2, The problem is gas exchange at the level of the alveoli, and for that reason, the client can hyperventilate. So the client has a respiratory rate that is increased. Why can the client increase the respiratory rate? Because the airway is open, the respiratory center is normal, and the muscles that participate in the respiration are normal. The problem is in the alveoli. In the alveoli, there is a problem, liquid pulmonary edema, pneumonia, atelectasis, whatever, that is producing a drop in the oxygenation of the blood. But the brain can order the lungs and the respiratory center and the muscle to make the client breathe 30 times per minute. What is that? Hyperventilation. Each time you have the possibility of having hyperventilation, you will have associated to the drop of the oxygen a drop in the concentration of carbon dioxide. But sometimes there is a problem in the respiratory center in the brain. Why? Opioid. Why? ¿Cómo se llama? A brain edema, an extreme brain edema. Or you can have a problem in the muscle. Which one? Myasthenia gravis in crisis. Or in the nerve. Which one? Guillain-Barré. Yeah, Guillain-Barré. Uh, or very simply, you have an obstruction in the pipes. This obstruction can be very severe in the trachea, like an epiglottitis, a severe epiglottitis, or a burn airway, or an angioedema in an anaphylaxis, severe anaphylaxis, or action of the ACE inhibitors, or a foreign body stuck there, or you have a narrowing, a diffuse narrowing in all the branches of the trachea that are the bronchi, like in a COPD. In those cases, either because the respiratory center is depressed, the nerves are damaged, the muscle are weak, or the airway is obstructed, the patient would like to hyperventilate, but can't. Okay? I would like to have a Mercedes, but I can't. You understand that, no? Okay, the patient would like to hyperventilate because the oxygen is also low. Also, in this condition, the oxygen is low, but cannot hyperventilate. So now the patient is hypoventilating because the respiratory center is damaged, because the nerves are damaged, the muscle are damaged, or the airway is obstructed. And then, as a consequence of the hypoventilation, the clients will have a form of respiratory insufficiency with low oxygen also with low oxygen, but increased CO2. So you had basically two type of respiratory insufficiency. Both have low oxygen, but one, like in pulmonary edema, pneumonia, atelectasis, etc., you have hyperventilation. The patient have low oxygen, but competent respiratory center, airway, muscles, and nerve, and can hyperventilate. But sometimes the patient have another type of, so in that case, this type of respiratory distress, this kind of, is low oxygen with low CO2, is hypocapnic, and the patient is clinically hyperventilating, breathing 30, 40 times per minute. But in some time, the respiratory center is damaged, or the trachea is damaged, or the muscle are damaged, or the nerve are damaged, or the bronchi are obstructed, and the patient cannot, okay, cannot, okay, hyperventilate. So in that cases, you are going to have also low oxygen, but elevation of the CO2. And the best way of remembering that is that the CO2 has an inverse relation with the respiratory rate. If the respiratory rates okay, can increase, uh, the CO2 will be low. But if the respiratory rate cannot, cannot increase, then uh, the CO2 will increase. Is more or less clear for you now? So.
Yes, Professor, it is clear. Thank you so much. It's just that, I never had nobody giving me the rules, and in
So
my
go
mind,
go
just
go to your book of med search, the Ignatevicius, and you'll find this explanation the same as I did. The two type of respiratory insufficiency, hypocapnic and hypercapnic.
thank you, Professor.
Capnic means CO2. Okay, okay. Okay, so those are deviation, but I just wanted, because I've seen so many question answers about this, that you need to identify this situation, and it confused a lot, okay, the students. So I wanted to discuss that. So, okay, this client is having low oxygen, but the airway is open, and the client can hyperventilate. That's why it has the tachypnea. And for that reason, you expect a low oxygen and a low CO2. A low CO2 is what you expect in the ABGs of this client. In the ABGs of this client. Um, very nice. Okay, client encouraged to cough and deep breath. The client is already spontaneous doing that. The client reports no difficulty with urination, but does have to get up several times during the night to urinate. Okay, so it is interesting that people that suffer of heart failure during the day, because they feel better sitting, they are sitting for long periods of time, and then their legs become swollen. Okay, so there is a lot of liquid in the legs of those clients during the day. So if you check a client at 6 p.m. with heart failure, you're going to notice ankle edema or leg edema, dependent edema. But then when they go to bed at night, usually they notice that their legs are swollen, and they elevate the legs in a couple of pillows. No, they go to bed and they do that. It's very common. So even without elevating with a pillow the legs, the action of going to bed elevate the legs. So now this liquid that was pulling in the subcutaneous, in the interstitial space of the legs, is going to move here and is going to be reabsorbed. Is going to be reabsorbed. Yeah. When this liquid is reabsorbed, is going to end, is going to end pumped by the heart to the kidneys, to the kidneys. And the kidneys are going to have now at night more liquid, and for that reason, the person is peeing more urine, okay, increased volume of urine during the night, because is peeing the liquid that was in the legs, pulled in the legs, that were not participating in the circulation during the day. Now at night, when it's reabsorbed, this liquid is going to participate in the circulation and is going to end in the kidneys and are going to be peed. That's why this client probably is complaining that have to get up several times during the night to urinate. Okay, the urinate. I insist again that those are clinical scenarios, those are clinical judgment questions. Not necessarily needs all this, but the understanding the pathophysiology of the disease that they try to present is important. Is important. So everything is fitting in heart failure until now. Vowel sounds in all four quadrants, which is expected. Client denies nausea. Last vowel movement this morning, no problem there. Peripheral IV inserted in right arm after one attempt with a 20 gauge catheter to have an IV available is okay. Client was escorted to X-ray for chest X-ray. Partner remains at the bedside. Another thing that we learn in those clinical scenarios, at least in my case, because English is not my first language, is to learn how to document when we start working in English. Okay, and I know that there are many students that are like me in the school. Okay. The questions say, the vital sign, because it's not necessary to read that. Vital sign, temperature is okay. I don't expect fever in this condition. I expect tachycardia. Remember that the consequence of having a fluid in the alveoli is drop of the oxygen. And remember that the brain enters in distress when the oxygen is low. And a brain activates the fight or flight reaction in clients that have low oxygen. In that case, you have an increase of epinephrine release in the body. So you expect the increment of the heart rate and the respiratory rate. So you have increased heart rate and you have increased respiratory rate. The blood pressure is acceptable. There is nothing special in this blood pressure. The O2 saturation, as we were suspecting until now, is low, even receiving oxygen through nasal cannula. The EKG, the 12-lead EKG, remember, because it's Nclex question, the EKG, the complete EKG has 4 cables, pardon, sorry, 10 cables, 10 cables attached to the body of the client. And those 10 cables will allow the computer, the machine of EKG, read 12 leads. Okay, so it's something that a nurse is supposed to know and has been tested in Nclex. How many cables have an EKG? 10. And how many leads are read? 12. Only this question is the one that I know have been in Nclex. I'm just sharing with you what I know. Sinus tachycardia with frequent premature atrial contraction, as I explained before. Okay, so it's sinus tachycardia. So now comes the question. Ya, eso está ya. Okay, let me decrease the size so I can see all the question. Decrease. Okay. The questions say, complete the diagram by dragging from the choices below to specify what condition the client is most likely experiencing. 2 actions the nurse should take to address that condition, and 2 parameters the nurse should monitor to assess the client progress. Once that you understand in the scenario all the physiopathology, okay, of the scenario, even if you are not a doctor, you can make a doctor or medical diagnosis, because those are medical diagnoses. And it is a new tendency that is developing the nursing in America. Okay, is the, the in some way abandon a little the nursing diagnosis and adhering to the medical diagnosis. And well, it is a reality, and we cannot change this reality. And this reality is in your ankles, and that's why you need to understand that. So the first that you need to do in those stand-alone type of clinical judgment question called bow tie, because it looks like a bow tie, okay, un lacito, okay, it's a smoking bow tie, okay. Oh Lord, sorry. Is what you need to do is to first identify the center of the bow tie. And the center of the bow tie, you need to choose a diagnosis. So you have here pulmonary embolism. Pulmonary embolism can produce a similar, but not equal, similar, okay, scenario of acute respiratory distress with hypoxia and hyperventilation. But the pulmonary embolism should have, at least in the scenario that you expect in the question, a past history of deep vein thrombosis. If we're talking about thromboembolism, that is the majority of the pulmonary embolism. So there is no history here of deep vein thrombosis. There is no history here of DVT. The pulmonary embolism tends to be more sudden, more acute. It is a client that is presenting acute symptoms since today, but in hours, while the pulmonary embolism, the beginning of the symptoms is in minutes. It's very sudden. In the moment that the piece of cloth from the leg travels quickly to the lungs and install obstructing the pulmonary circulation. So that's why pulmonary embolism doesn't look to be this clinical scenario. We can rule out that. Angina, as I said before, the absence of chest pain, okay, goes in against the acute ischemic heart, no, acute coronary accident, because there is no chest pain. And the angina alone cannot explain those symptoms of heart failure that the patient is experiencing. Deep vein thrombosis is presented as one leg that is swollen while the other leg is not swollen. In a patient with risk, yes? This swollen leg, this unilateral asymmetric swelling of one leg, uh, is annoying the clients. Is producing a mild to moderate pain, some warmth, yes, and this is a DVT. This client has risk factor for DVT. The risk factor is the heart failure. Heart failure is one of the risk factor for DVT. Immobility, leg trauma, use the estrogens, etc., are the other risk factor more frequently. But the client in any moment have been described local symptoms of the legs and are not, presenting symptoms that suggest pulmonary embolism. That's why we rule out also DVT. And we, since the beginning, have been suspecting heart failure because the history of the client that has a previous heart problem, the, ¿cómo se llama? The presence of orthopnea, the S3 and the auscultation, and uh, uh, the difficulty, the respiratory problem, and with orthopnea, and all the other manifestations. The X-ray would be very useful to diagnose heart failure. What should show the X-ray? A very enlarged heart, okay? An enlarged heart, okay? An enlarged heart. And then the lungs would be seen with liquid inside the alveoli. So it's going to produce an image that looks like a cotton, okay? A whitish diffuse stuff with very pronounced blood vessel that translate there is too much liquid inside the lumps. This is the X-ray that the client has, but they didn't give us the result of the X-ray. And there is a blood work that is in NCLEX that can also support the diagnosis of heart failure. Nobody remember the name? Okay, is B N E. B natriuretic peptide. Yes, which is abbreviated BNP. Okay, you expect that this client should have the BNP higher than 100 picograms per milliliter. Okay, so the BNP should be elevated. When you study, trying to remember to review all those stuff that could be in a different, so you can have perfectly a, 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 a clinical case of heart failure, but then you can have the 6 questions related to the clinical case, which is the other presentation of the clinical judgment question that we'll have in the test. And then, of course, you are going to have all those details tested, no? Yes. The echocardiogram, echocardiogram is a wonderful test that will also show the enlargement of the heart and even can calculate the degree of heart failure, calculating the cardiac output of the patient, specifically with a term that is called ejection fraction. The ejection fraction in clients with significant heart failure will be less than 50% the normal. Ejection fraction when the ventricle is in diastole, is relaxed, the ventricle is dilated, is expanded, okay? So can fill with blood. So the ventricle is filling with blood. And then when comes the systole, the ventricle contract because it's a muscle, contract, and the contraction will push or eject this blood, this blood that was taken during the diastole. This blood is ejected to the aorta. Yes? Uh, the ejection fraction is the percentage of this blood that was present at the end of the diastole, all this blood that was present at the end of the diastole, which part, which fraction was sent to the aorta. Never the ventricle empties totally. Always leave a small or an amount, not small, an amount of blood at the end of the systole. So you always have some blood inside the ventricle, but usually the ventricle can eject at least more than half the blood that was at the end of the diastole. So suppose that this ventricle in the diastole had 100 milliliters of blood, and then the ventricle contract and it is left only 30 milliliters. 30 milliliters. What means that? That the heart ejected 70 milliliters to the aorta. So the ejection fraction of this ventricle is 70%. Why? Because they will have 100 and you push, you spit out 70, it is 70%. And anything that is above 50% in the echocardiogram is okay, and it is called ejection fraction, and it's very useful to diagnose heart failure. When there is less than 50% ejection fraction, it is a confirmation that there is heart failure in the client. I saw a similar, heard about a similar question in Anchor, so I wanted to make you know what you can do with an echocardiogram in the heart. Can be, you can see the heart. So the doctor can see the heart, okay, in the same way that you see a baby in the uterus of a mother. You can see the valve, you can see the pericardium, and you can calculate the ejection fraction. That is this stuff that I explained. The BNP is a substance that increases when the heart is enlarged in heart failure, and that's why it increases this blood work in heart failure. And the X-ray also is useful to see the size of the heart and to see the accumulation of liquid inside the lungs, in the flesh of the lung. So definitively, okay, in this clinical scenario, we have a case of heart failure. So now we need to decide of these 5 actions, 2 that are pertinent for this client. And then we have administer a diuretic. I like that because the diuretics is the cornerstone, is the main part of the treatment of the heart failure. Obtain the client's weight. It is important to take daily weight, but we need to wait until read all to choose only 2. Administer nitroglycerin sublingual. Well, if the client were having angina, it could be okay, but in this case, is not indispensable. Is not necessary. Begin a heparin infusion. So IV heparin in a maximum dose. This client, probably the doctor will order heparin, but low molecular weight heparin. I mean enoxaparin. This enoxaparin is administered subcutaneous in the abdomen. It's not administered never intravenous, and is with the purpose of for prevention of DVT. Because I mentioned before that this client with heart failure are at increased risk of deep vein thrombosis. So you expect enoxaparin, but you don't expect an IV infusion of heparin because those strong administration of heparin are used when you have a DVT or already DVT or pulmonary embolism as part of the treatment of those conditions. And administering a sedative, I don't see the need because the patient is restless and the patient is hyperventilating, not because it's with anxiety or with panic attack. It's not psychological, the origin. The origin is the decreased oxygenation of the client. So ruling out, those are the best two options. Why I weigh the client daily? Because any change in the weight translate retention or elimination of fluid. So what I expect after the initiation of the diuretic is a drop from one day to the next of the weight of the client. Remember that if they tells you that the client was weighing, so vamos a poner un gordo, 100 kilos, Nclex works with kilos and metric system. I I don't remember any student telling me that had to convert pounds in kilos. But suppose that the patient is weighing, okay, 60 kilos, which is the use, okay? But let me say 100 because it's a round number. It's easy to visualize. And tomorrow, the client is weighing 98 kilos. How many liters of liquid the client eat and eliminated? How many liters of liquid, of water the client eliminated?
Is it a two?
Two, 2 liters, because
One,
each
one liter.
liter weighs 1 kilo, okay?
1 kilo, exactly 1 kilo.
So the clients eliminated in this 24 hours 2 liters of liquid. And this is an English question. It's an English question, okay? That how it's a calculation question, okay? Where they say how much liquid you anticipate the clients eliminated, and you, Cloud, I gave you very round numbers, so you don't take the calculator, okay? Because everybody knows that 2 liters is the difference, okay? But they can make that can give you a little more complex numbers, okay? And yes, you can anticipate the clients is responding properly to the diuretic, okay, with those interventions. And then the other part of the bow tie is the evaluation, because remember, nursing assessment, nursing diagnosis, plan, interventions, action to take, and then evaluation. So the evaluation of what you did. So what are the parameters that you need to monitor in a client with heart failure? You have the troponin level. It is for myocardial infarction, so it's not pertinent here. B, natriuretic peptide. I already mentioned that. Okay. And then B natriuretic peptide is going to be proportional to the severity of the heart failure. Some patients have the elevation of BNP in the order of the thousands. Okay. And then you see how the BNP start dropping when the client returns to compensation, to improvement uh, to the of the heart failure. Bleeding precaution. Why? If the client is not receiving, okay, anticoagulation. Petechiae on chest. I look for this in fat embolism, no? Petechiae on chest is seen in fat embolism, maybe in endocarditis, bacterial endocarditis. Why petechiae on chest? And then pulmonary edema. Yes, this client is having pulmonary edema. So I need to monitor anything that had to do with pulmonary edema. How I evaluate pulmonary edema? Well, auscultation will give me crackles or rails if there is pulmonary edema. But then those crackles are going to decrease progressively, okay? At the beginning, the crackles are going to be heard all along of both lungs, on all the extension of the both lungs, on all the lung fields, no? But then the crackle is going to be heard in the lower part, and then the crackles are going to be scanned until it's appearing. This is a way of evaluating clinically pulmonary edema. Also, I will notice that the patient can breathe much better, tolerates the recumbent position, so has no orthopnea. And remember that it's important to ask the clients at home how many pillows they are using to sleep. Because if they are using too many pillows, it's because they don't have a clinical bed at home. Yes, they need to keep the elevation of the chest because they have orthopnea, because pulmonary edema, they need many pillows. But if they are sleeping with one pillow, it's because they are tolerating the recumbent position and the pulmonary edema is improving. Remember also that coughing, coughing is a manifestation, can be a manifestation of pulmonary edema, especially if it happens at night when the edemas are reabsorbed and more liquid arrives to the lungs. And remember that tends to be a wet cough, and even the client can expectorate a pink and frothy sputum, which is no more than the liquid that is in the alveoli. Okay, so I trying to squeeze the most common aspect of heart failure, trying to extend these questions as a possible clinical case of heart failure with 6 questions, okay? With 6 questions. That is the most extended a clinical judgment, new generation question that you are going to have. Okay, a simple question, but remember the 80% of your test will be the traditional questions, okay? And I personally, it's my opinion, it's not an official opinion. I think that those questions are easier, are time consuming, and requires mastering the language, because you need to understand all this blah, 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 yada, 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 yada. Yes. But are easier. Sometimes these short questions are more difficult. Okay, a client is admitted 24 hours ago with acute diarrhea and is wearing an adult incontinence pad. What action should the nurse take before visitors arrive and enter to the client's room? Ask each visitor to dress in gowns and wear gloves before entering the client's room. Call the healthcare provider to request an order for a private room. Verify that each visitor is wearing a mask if less than 3 feet from the client. Remind all visitors to use hand sanitizer before entering and when exiting the room. Okay. So this is a question. And what do you think? What should the nurse do before the visitors arrive and enter the room? The client has a diarrhea, an acute diarrhea. We are assuming that this is an infectious diarrhea. We know that diarrhea can have many etiologies. It can be, for example, the most common are viral diarrheas. Uh, the um, the rotavirus and the norovirus case are enterovirus that produce diarrhea very commonly. So viral diarrhea. And also there are bacteria like E. coli, enterotoxigenic, E. coli, or Shigella, Salmonella, uh, Campylobacter, that are bacteria that can produce diarrhea. The Center for Disease Control, okay, that give our regulations in infection control, at least in the rest of the country, not in Florida, uh, says that the diarrheas are standard precaution unless the client is incontinent. If the client is incontinent, like a child that is diapered, okay, pre-potty trained, or an adult that becomes incontinent, which is very common in older people, then you need to escalate the infection control to contact precautions. So this is the theory, the knowledge that you need to have about infection control in diarrhea. So you have a diarrhea or Shigella, Salmonella, E. coli, or ¿cómo se llama? Viruses, but you are continent and you know how to wash your hands. Standard precaution, standard. You don't need to be in contact precaution. But if you have a incontinent client having acute diarrhea, the client must be in contact precaution. Once I review or refresh the infection control of acute diarrhea in this client, okay, what do you think should be done before visitors arrive and enter the client room?
Contact precautions?
Well, of course, we need to initiate contact precaution because the client is having acute diarrhea and the client is incontinence. But then of this A, B, or C, D, you can, rule out some of the options are easily, okay, to
That's gonna
eliminate.
be
But
D.
okay, D as in David, okay, D as in David. Remind all visitors to use hand sanitizer before entering and exiting the room. Okay, so it is correct. It is correct. Doing that, it is correct. Doing that is correct. Okay, as far as it is not C. diff. If the client has a C. diff, I am not completely sure if the client is having the diarrhea because C. diff or any other of the diarrhea that I mentioned is not mentioned here. If the client has a C. diff, should not work the hand sanitizer. Need to be hand washing. Yes. So because this is an objection at this option in my test, I put a question mark here that it could be a right intervention except in CD. Everybody knows it's not novelty that C. diff cannot be killed by alcohol. That C. diff has spores and the spores cannot be killed by hand sanitizer. Is the exception, the main exception to the use of hand sanitizer. In the other cases, the other etiologies works the hand sanitizer, but not in C. diff. So, okay, it is not a bad recommendation, but it's not covering C. diff. And the diarrhea could be C. diff because they don't say which agent is producing the diarrhea. Any other suggestion? I want to, because I don't really remember the answer key of this question, or I don't know from this, if this question is coming from where. So I want to discuss that. Imagine that we are in the test and we are analyzing which probable options to choose. Trying to imagine that you are the nurse. The family has not yet arrived. Yes, and and when the family arrive, which intervention, okay, you take before visitors arrive and enter the client's room? What about the mask? What do you think about wearing a mask, a
No.
surgical mask?
Is not
What you
part of contact precaution.
is not
It's not.
necessary in contact.
It's,
So we can rule out that. And when I rule out
but
one
it's no
option,
precaution.
exactly, I feel better because now when I see less options, okay, I feel less stress. So trying to understand the question, it's a question bank question. I don't know what, I think it was ATI or okay. So I've this question. What do you think is pertinent? Is pertinent to request an order for a private room for this client?
I don't think so, Professor.
Why?
No.
Because we
Contact
have
precaution doesn't require isolation.
Yes.
it does, but it's not giving us enough information on the question.
Well, the client is having acute diarrhea and is incontinent. So the client needs, we already discussed this point, the client needs contact precaution. Okay, contact precaution. when we have clients in contact precaution, droplet precaution, and airborne precautions, we shouldn't require a isolation room? I think that yes.
Yes.
So it is okay. We use isolation room, private room, yeah. And when we can place two clients that are in contact or are in droplet in the same room, by the way, it's called cohort. You know that it is called cohort, no? When we
Yes.
Okay, when we do that, when we demonstrate that the two clients has the same agent, the same virus, the same bacteria, okay, producing the same disease. So it's something that we need to know and master. We clients that are in contact, clients that are in droplet, and clients that are in airborne should place those clients in isolation. Isolation means that they are going to be isolated in a room. It means they need to be in a room. So isolated in a room. Yeah. When we can put a fellow, a company in this room, yes, is we have the very rare circumstance of having two clients with the same disease produced by the same agent, the same bacteria, the same virus, etc. And this is called cohort. And there are many questions of when you can cohort. Otherwise, if there is not other client with the same type of diarrhea, the same agent diarrhea, you cannot place another client here because the client is in isolation. Those three stuff is called isolation. The clients with infectious disease that are only standard precaution, like HIV, which is an infection disease, that's the hepatitis, anthrax, yes, Legionnaire disease, etc., etc. Diseases that are a standard precaution, they don't require isolation room. But if the clients need contact, droplet, or airborne, those are isolation interventions. And the client must be isolated and should be alone in the room or cohort with a client with exactly the same disease, the same agent. It is something solid, is something that is well established in infection control. Okay, so yes, a client that is in contact precaution should be isolated. Why? Because can transmit his or her disease to another client, can be passed from person to person. Even just touching the same doorknob or touching the same table or touching the same remote of the TV, okay, etc., etc. That's why you cannot put, okay, another client with another disease in this same room. The contact precaution requires, okay, isolation. So it is correct. And then you have asking each visitor to dress in a gown and wear gloves before entering the room. Is this correct?
No,
Why not?
they are not
Because,
in contact with the
well, you
with
don't
the
know. You don't know. I insist in contact precaution theoretically. Before entering the room, you should be wearing gloves and gown because your hands and your clothes, okay, are uh, exposed when you approximate to the bed and you rub slightly the border of the bed of the client, maybe there in this mattress, in this linen, there is the bacteria, the virus, or the scabies, whatever that has declined. And the same for your hands. That's why the expert says that before entering a client in contact isolation, the client should, the people entering there should be wearing gowns and gloves. So I don't see any objection to this issue, because if these people enter the room of the client's isolation and then they are not using those personal protective equipment, and they get the bacteria, the virus in their glove or their hands and leave the room, they are spreading the infection. And the purpose of the isolation or the infection control is to stop the spreading of the room. So I see that those two options are true. It is the way that I'm trying to analyze this question in my Nclex. Yes, in my Nclex. And so the detail is, the trick of this question is before the visitors arrive, okay, and enter the client's room. So what would be of these two first?
A.
A.
It's A because it's asking before they arrive and enter the room. So before they arrive and enter the room, they should be already
And
wearing
when
the
and
gown.
when and
Is
when
it
I
before? If it's before they arrive,
Leave
should be
from.
B. You change.
The
You
room.
put the
in
Leave
proper
which
from first.
moment
preparation and
I move the
isolation
client,
first
yes. In which moment I move the client to the
before they
private room
arrive.
after the
When do you
families
do
are
that?
with it.
It's contagious. No.
So it is
Yeah, but the way the question is asking, like the way the question is asking before visitors arrive and enter the client's room. It's kind of like the room is already there. You get what I don't know if I can
it's
explain
it's
it.
it's, it's like a confusing, no? So it's a question, it is a bank, a question from a bank. Is a question that could be having, okay, two possible.
Look easy, but is un enredadera.
Professor.
Jose, I think you're muted. Cannot hear you.
I mute myself, but not to him.
I think that somebody muted me because I didn't mute it. It was a Professor Valdes. Okay.
Professor, what I would say about this question is that the fact that they're telling you that the patient is incontinence
Yes.
is triggering the fact that you need to not only go into standard, but also with contact precaution.
Yes.
And I will go with A. I will not go with D.
Okay. So you eliminated D. Okay. Because they could be a CD.
Correct.
Okay, so it's between A and B, and I think is I remember the intention of the question is that even the visitors need to wear gowns and gloves. So everybody entering the room need to be wearing gowns and gloves, okay, before entering the rooms. And yes, everything was before enter the room. Is it everybody in the door of this client that can be left open, there is a sign that says don't enter without talking to the nurse. Outside the door should be a table with gowns and gloves, disposable gloves. And before entering, you need to wear gowns and gloves. Yes. And
online,
yes.
and they tell you when the question has the fact that it's incontinence, they want you to
Yes.
immediately into contact precaution.
Correct.
So
Correct. So this is what we learned of this question, because remember, the question is not going to repeat exactly the same in English, but is what we learned in this question. The acute diarrhea.
Professor, I'm
Yes.
sorry, I have a
Yes.
question. When they
Sure.
said about incontinence, it's not pee, it's a diarrhea?
It's diarrhea.
Okay,
It's incontinence of number 2. Yeah.
okay,
So
thank you.
remember, it is the fact that if any of us that can hold and have a diarrhea that is infectious, we don't need to be placed in isolation. Only, insist in washing your hands and avoid preparing food for others. This is what the infectologist recommend if you have a diarrhea. You don't need to be in isolation, but please, because you are continents, you are not spreading the poo-poo all over. But please, when you go to the bathroom, clean carefully and wash very well your hands. And avoid preparing food for others. Yes, to minimize the risk of transmitting. This is the result. But if you are incontinent of number 2, then you are going to have, I don't know, obviously you don't have too much experience in incontinent clients, but this is something that in Spanish ends in azon, okay, all over. Okay, there is a spread of poo-poo all over, in the bed, in the linens, in the floor, in the gowns, and the hands of the client, all over. And then there is a world of infections in this room. And then the client should be placed in isolation, alone. Can be placed another client with the client? Yes. It's demonstrated that other client has exactly the same bacteria. And it's very difficult that you have exactly 2 clients with the same culture demonstrating the same bacteria at the same time. That's why usually those clients need to be placed in isolation. But don't forget, guys, that contact, droplets, and airborne are isolations. Okay, the only one that is infectious but doesn't need isolation is a standard precaution. Okay, is alone, standard alone. Okay, and the other thing that we learned is that when a diarrhea requires contact precaution is when the client is incontinent. Okay, so Okay, let's move on. The parents of a school-age child admitted for dehydrations are providing information to the nurse about their child. Which of these concerns would the nurse recognize as a finding that could suggest type 1 diabetes? This a similar question has been coming in English, very common. How can they view a child with type 1 diabetes, anorexia, craving soda to weight gain, bedwetting?
We had a question similar to that one on the last exam, Professor.
Okay, so you answer what?
Uh,
D.
in my case, no, I don't remember exactly what I answered.
Or you need to take medication for your memory. You need to take vitamins. Okay, Jingo biloba. Okay, okay. Remember that the number one symptom of the elevation of the blood sugar in the blood is that this sugar is going to spill in the urine, producing what is called osmotic diuresis. So the number one symptom of diabetes is the polyuria. The polyuria. When we are talking about a child, there is a condition in childhood that sometimes happens in adulthood, but it's rare. Yes, that is the enuresis or bedwetting. Yes, so the classical presentation of the type 1 diabetes that appears very acutely in childhood, if the child is a school age, suppose that is a child that has been controlling a sphincter for many years, is a child in third grade. Okay, uh, 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 is start uh, wetting the bed again because it's having this increased volume of urine. This polyuria brings the second in appearance, okay, symptom. That is the dehydration that producing thirst. And the thirst produces the polydipsia. So this is the sequence of the debut, the presentation of diabetes. The osmotic diuresis and increased urinary output, I meant the polyuria, that could be represented by the bedwetting, because a huge amount of urine that accumulates in the blood of this poor child during the night is too much to be contained, and then the child can have accident. Okay, they tend to lose weight. Craving sodas is not a specific of diabetes. And then because the brain is not receiving the brain cells, specifically the brain cells that are in the hypothalamus that controls our hunger. Yes, those cells, the glucose to enter those cells requires the presence of insulin, because there is zero insulin in the debut of the type 1. The glucose is not entering inside those cells that tells you, hey, you're full, hey, you're enough. And then that's why the client is having a lot of hunger, and that's why it has polyphagia, no anorexia, polyphagia. So you can rule out anorexia, because by the contrary, diabetic clients are hungry all time. Craving soda because it's not specific. And weight gain because they lose weight. And then bedwetting is the best answer of this, because bedwetting is the expression of the polyuria.
Professor, I saw the same question, but it was flipped around and it was a select all the apply.
Okay.
And what it was telling you, it was that the patient had diabetes type 1. And then it said something like, oh, what, you know how sometimes they'll ask you stuff like, what makes you sure that that's what they have, that they have diabetes type 1? Like, what are the kind of like the signs and symptoms? And then that was one of the options, bedwetting, and it was also a child, but the question was
Okay.
totally flipped.
Yes. But remember that in childhood is when you can have those accidents. You don't have rarely those. It's very rare those accidents in adulthood. You wakes up, but the sleeping children is very deep, and they can they don't awake. They are not aroused by the urgency to pee, and that's why they have those accidents. And it is a presentation, a classical presentation of diabetes type 1, because it's the one that presents in children. Okay, so learn this question, because I heard that this question is coming frequently in Nclex. Not this question, this topic, this presentation, that, as she said, can be flipped around and can be changed and can be transformed in a scenario that apply, or in a clinical scenario, and then you have a clinical judgment question, yes, of a type 1 diabetes debut, okay, beginning in a child. The nurse is reviewing the medication administration record for a 72-year-old client scheduled to have a cardioversion. Okay, a 72-year client that is going to have an electrical shock elective or a dysrhythmia, probably an atrial fibrillation. Prior to the procedure, the nurse should notify the healthcare provider if the client is receiving or received which medication in the preceding 24 hours. Diltiazem, which is a calcium channel blocker, digoxin, which is an inotropic positive medication, nitroglycerin ointment, and metoprolol. So this client is going to a electrical shock, a synchronized electrical shock, to return, or to stop and return to a normal, to stop an abnormal rhythm and return to a normal sign of rhythm. There is one of these medication brings or give problems, okay, to clients going to electrical shock. Which one do you think it is? It is
Is it D,
D as in David.
David?
No, it's B as in boy.
Digoxin?
Is B as in boy. The dioxin should be discontinued 48 hours before an elective, okay, cardioversion. Elective cardioversion. Just a second. Okay, an electric cardioversion. When you have an electric cardioversion, because the client has, for example, an atrial fibrillation, they can convert the atrial fibrillation back into ya va un segundito. Okay.
It's interesting because in my mind, I thought if because of the medication, which is a beta blocker.
Yes, but there's no contraindication to the cardioversion. The problem is the dioxin. Need to be discontinued, the dioxin, before the cardioversion. So remember that when the client is having an electrical shock, you need to discriminate what is synchronized cardioversion versus defibrillation. The cardioversion is elective. That's why the client must sign a consent form. And the client is stable, is hemodynamically stable or relatively stable, generally. And the client is conscious. So need to be sedated, need to be be sedated with propofol or something, because the electrical shock is going to hurt a lot. Yeah. And the characteristic of the electrical shock is must be synchronized. Must be synchronized. Synchronization meant that that when you have an EKG PQRST, if the electrical shock falls in the T or ST segment, kills the client. Make it simple. Produces a ventricular fibrillation. So the electrical shocks need to fall, need to occur exactly with the QRS. So the machine, only the machine can be fast enough as to know in which moment the electrical shock should be delivered toward the client, you know, and that's why it requires a special cardio vector or machine that is able to synchronize the EKG of the client with the source of the electrical shock. So when you uh, uh, push the synchronization button, so the synchronization is on, you see that the machine will produce like a mark in each QRS that in this picture here and circling the mark. Sometimes it's a chevron over the QRS, but it's just the machine telling you that it's synchronizing the QRS. And when you order the machine to deliver the electrical shock to the client, the electrical shock is going to be delivered exactly in the QRS, avoiding the triggering of a ventricular fibrillation. That's why the cardioversion needs to be synchronized. The chest of the client need to be dry, should not be wet. And, ¿cómo se llama? Any patch that could be present in the chest should be removed, And, um, and and that's it. And if the client is taking dioxin, the dioxin must be discontinued 48 hours before the elective electrical shock, because the dioxin, when the myocardium is impregnated with dioxin, because the patient has been taking this medication before and receive an electrical shock, the clients frequently, the evidence has demonstrated that frequently develop ventricular fibrillation, ventricular dysrhythmia. That's why the dioxin must be discontinued. Okay, so it is important. The defibrillation is different. The defibrillation is given only the cardioversion is given for those supraventricular rhythms, like ventricular supraventricular tachycardia or atrial fibrillation, atrial flutter, that the doctor wants to revert and convert back into a normal sinus rhythm. The defibrillation is used only when the client has no pulse, when the client is having a ventricular tachycardia without pulse, or a ventricular fibrillation. This is the indication of the defibrillation. In that case, the defibrillation is not synchronized because the client is dead. The client is without pulse. There is no need of sedation. And of course, because it's an emergency, there is no need of consent if the client is a full code. Okay, so it's a, a reminder. Okay, a reminder, guys. When you want, if some of you are having problem with cardiovascular, I telling you, ask me, and then I can cover any one of those topics, okay, that you want to review, because content is also important, not only questions. I'm trying to cover the content. When I practice the question with you, as you notice that I advance very slowly because I'm covering content with you. But well, the answer of this question is dioxin. So it's something that you need to learn. That's it, period. It's something that you need to learn and memorize that. So it's not metoprolol, it's not nitrodiltiazem. Okay. Remember that metoprolol and diltiazem, even if they are different medications, are very similar. They are chronotropic negative. Chronotropic is the capacity that of certain medication have of increasing or decreasing the heart rate. That's make the chronotropism could be positive or negative. A medication that can increase okay, the heart rate, like for example, atropine, for example, epinephrine, yeah, okay, is chronotropic positive. Chronotropic negative are medication that slow down the heart, decrease the heart rate. The metoprolol, beta blockers, and diltiazem and verapamil, calcium channel blockers, are chronotropic negative. So for strategies, if you know diltiazem and metoprolol that have more or less the same action, are chronotropic negative and inotropic negative. Okay, they decrease the strength of the contraction also. Because they are so similar, probably they were not the medication that we're talking. Nitroglycerin ointment that is applied in the chest as an ointment with a paper is probably not. So is dioxin, but it's very difficult through a strategy, okay, reach to the answer. It's better to have the knowledge, and you already acquire the knowledge. I deliver this knowledge, and you can verify this knowledge in your textbooks. Okay, dioxin should be discontinued before elective, okay, cardioversion. Which if this client is having the most common reason for cardioversion, which is AFib, this client must have a test before the cardioversion that rule out or discard the possibility of clots in the heart. Which test is that? You know that? Never heard that? Okay, you are needing, I think, a content review, guys. It's called transesophageal echocardiogram. Classical question in NCLEX. Okay, when a client is in atrial fibrillation, the atriums are not contracting. The ventricles are just contracting. The ventricles are pumping blood. The client is alive, even is stable. But the atriums are not contracting. In certain angles of the atriums, called the appendage, then the blood becomes stagnant and can form clots. So you can have clots in the atrium of the client with atrial fibrillation. That's why those clients are placed in anticoagulants to prevent the formation of those clots in the atriums. Understand that if those clots accidentally move this place to the ventricle that is just contracting, is contracting, then the ventricle will pump this clot to the aorta, and the aorta has a couple of arteries that emerge directly of the arc of the aorta that are the carotid arteries. So frequently those clots travel to the brain, producing stroke. That's why the atrial fibrillation is a common cause of embolic stroke or brain attack. And that's why atrial fibrillation clients are anticoagulated. But sometimes doctors want to give an electrical shock, synchronized electrical shock, I mean a cardioversion to those clients to return the client to normal sinus rhythm. So to eliminate the atrial fibrillation with the electrical shock, resetting, okay, the electrical activity of the atriums and returning the client to a normal sinus rhythm. But if they do this, then the atriums will start contracting, and the doctor must be completely 100% sure that there are not clots in the atrium if they order the atriums to contract again, because obviously if there is a clot here and the atrium will start contracting, mandatorily this clot is going to be moved, pumped to the ventricle, and from the ventricle to the brain. And for this verification, they do an echocardiogram, but it's not the usual echocardiogram. The usual echocardiogram is done in the chest. the exploration, the probe, okay, the transducer, which is the proper name of what is placed in the chest, in here, in the chest, with a gel, is a transthoracic echocardiogram. The transthoracic echocardiogram allows to see perfectly the ventricles, but not the atrium. It is due because the anatomic position of the heart is like recumbent in the chest, and the atriums are toward the center and adjacent to the esophagus. So they need to do an endoscopy. They need to do an endoscopy in those clients and then introduce through the mouth and the esophagus the probe of the echocardiogram. And then they do a through strands, okay, esophageal, esophagus, echocardiogram. And this is a classical question in Nclex before an elective cardioversion, like in this question of an atrial fibrillation, which test must the nurse verify that is done, is an TEE or transesophageal echocardiogram that rules out the presence of clots in the atrium. Sorry, I just sharing with you the stuff that I learned from the NCLEX and to share with you the level of knowledge that you require for that. Other question that had been in this topic is that which kind of care the nurse need to deliver, to provide to a client that is having a TEE, okay, a TEE, okay, because you need to understand the client had an endoscopy. A client having an endoscopy to do this echocardiogram, TEE, need to be MPO. It's an invasive procedure, need to give consent. The client will be sedated, so the clients will be sleeping. And for that reason, the client cannot drive back home, need to bring somebody to drive the client back home. And those are English questions. And the client will have anesthesia, local anesthesia in the throat. And for that reason, the gag reflex and all the reflexes that are protective of the aspiration are going to be inhibited by this anesthesia. And then you need to observe, keep the clients, to prevent aspiration and prohibit the client from drinking or eating until you verify that this gag reflex has returned. So all those topics has been in English when they talk about the TEE. NCLEX wants you to know a lot of tests, a lot of tests, because remember that um, when the doctor orders a test, the nurse is the one that is going to take care of the details of those tests, like for example, keeping the client's MPO, etc., etc. So it is another chapter that is good to review. Most commonly practiced test. Okay, so now we learned this, and we learned a little about this cardioversion and this dioxin that is contraindicated, etc. Let's see the following. A nurse is caring for a 14-month-old just diagnosed with cystic fibrosis. Cystic fibrosis is another disease that is so common in English. The parents state that this is the first child in either family diagnosed with this disease, the first case in both families. And they ask about the risk to future children. What is the best response by the nurse? 1 in 2 is the chance to each child that you have in the future that would have the disease. 1 in 4 is the chance for each child that you have in the future to carry the trait of the disease. 1 in 2 is the chance of avoiding the trait of the disease, which is the same. And 1 in 4 is the chance for each child to have the disease. Based on your knowledge, what you should be answering?
D.
D as in David is the correct answer. And you need to memorize this chance, this percentage. because applies to any recessive inheritance pattern related disease. So this chance applies to cystic fibrosis. This chance apply to sickle cell disease. This chance apply to PKU, phenylketonuria, etc., etc. So each time you study diseases that are tested in anchors that are genetic, are hereditary, yeah, and the pattern of inheritance, of Mendelian inheritance, is mentioned as recessive, you need to know that this is the chance. This is the chance. Remember that for recessive diseases, the parents need to carry the damaged gene, but they don't suffer the disease because they are carrying. All we have two genes. Generally, we have two genes, okay, for each trait. Trait is whatever, the size of your nose or the color of your eyes, or if you are having a genetic disease, a hereditary disease. Those are gonna say trait and mentioning this. We carry in our genome, in our DNA, okay, genes to code those traits, any of those traits, including diseases that are pairs, are two genes. One gene is coming from dad, one gene is coming from mom. One gene from dad, one gene from mom. And then when two individuals, okay, a man, a biological man, a biological woman, join their gametes, I means their uh, reproductive cells, okay, they can transmit only one gene, each one of them. So when you are, this is a man and this is a woman, and you are making a baby, yes, you can, for example, suppose that in this condition, both Papa and Mama are carrying the trait, but they don't suffer the disease. Suppose that the trait is the red, the blue, see that is the blue, but to leave that at the last. So when they combine, they have this following possibility for combination, combining this with this. The red is normal, yes? So this child, we have the two genes of this trait normal. So this child clings, clings his genome, so is not carrying, this child is not carrying the abnormal gene. The other possibility is combining this red also, this red with this blue, In that case, this child is like the parents is carrying the trait, yes, is carrying the trait, but is not suffering the disease. When I combine this red with this blue from mom. The other possibility is that combining this blue, that is the sick gene, with this red of mom. Yes, in that case, is the same. Is another child that is carrying, is like the parents, is carrying the trait, but is not suffering the disease. And the last possibility is that combining this blue gene with mom blue gene. So now I have a child that has both genes sick. When both genes are sick in a recessive disease is when you suffer the disease. So what you have here, 1 in 4 possibilities, which is the same as 25%, because 1 in 4 or 1 divided by 4 is 25%. And this is the chance. So 1 in 4 of a child carrying the disease, 2 in 4 of children carrying the trait but not the disease, and 1 in 4 of having a child not carrying the trait, neither the trait nor the disease. Yes, so this is the Plummer squares, as it's called, the combination of genes possible. It is chance, it is possibility. Each time they make a baby, yeah, they make a baby. Okay, so that's why from this comes this, and you need to know that because it's frequently tested. It applies to all the recessive diseases. A nurse is caring. See, if you have a question, interrupt me with a question. A nurse is caring for a client whose family practices Chinese medicine. The nurse anticipates that in case of disease, the priority therapeutic goal for the family will be which of these? Is another question that is in English. I had this question in my English, not exactly like this, but this topic. Maintain a balance of energies, reject Occidental medicine, use of herbal medicines and acupuncture, restore yin and yang equilibrium.
D.
Yes,
D.
this is the answer. The yin and yang are the two forces in the universe that need to be in equilibrium. Yes, when there is a loss of the equilibrium between the yin and the yang is when disease appears. And for example, there are diseases in which yin is winning, and there are diseases in which yang, okay, is predominant. They need to be even in equilibrium. Anyone should predominate. Anyone should be winning. Should be both should be equally strong in equilibrium. If one of them becomes stronger than the other, is when disease appears. The yin is associated with cold, with the cold temperature, no? And diseases like pneumonia, flu, coronavirus, the postpartum, etc., are considered yin conditions. And the patient is too cold, so anticipate that the person is consuming very hot, okay, beverages and food, etc. Okay, Yang is more other diseases like hypertension, heart failure, cancer, yes, and then the client will be consuming cold stuff, refreshing stuff. Okay, it is an example of that. So I don't know, it sounds familiar to you, but when a person that believe in those traditions, especially a Chinese people, had a baby, uh, they don't they don't shower or wash their heads in a period of 40 days, and they are drinking a lot of hot food, and they want the AC, the air condition of the room in the hospital, warm. So if you are dealing with a traditional Chinese family, and remember that America is a, a, a country that has a lot of different cultures, okay, gathering here in a melting pot, you can have this situation, and you need to know that. And because it is an important group of the population, it is a common question in English, a very common question in English. I don't know if you are Hispanic. We Hispanics have very in common with the Chinese people belief about this, the traditional Hispanic belief. And I noticed that there is a lot of common practices in Chinese medicine that are also practiced in traditional Hispanic cultures. So some connections, need to be there. The nurse has established a psychotherapeutic relationship with a client. Okay, this is a therapeutic relationship. Yes, a therapeutic relationship. In this case, is mentioned more specific to psychotherapeutic, but is therapeutic communication, therapeutic rapport, therapeutic relation, etc. The nurse understands that a therapeutic nurse-client interaction occurs when a nurse takes which of these actions: advise the client on ways to resolve problems, praises the client for appropriate feelings and behavior, assist the client to clarify the meaning of what the client has said, reassure the client when the client is taking healthy decisions. What option you consider is the therapeutic?
D.
You say B as in boy?
D as in cat.
Oh, C as in cat.
I think it
For
should be
me, I think it's B. I think
C.
it's B.
B as in boy. D as in cat. Okay, what is the role of the nurse? To patronize and patronize is the word. The client, or to help the client to overcome him or herself, the client, the problems, okay, by themselves. What is the role of the nurse? To be the mama and the papa of the client, or to be
No.
a person that potentiate the individualities and the own powers of the client? It's a concept that you need to have very clear. You promote independence. So you don't give advice, because advice is what your grandmother or your mother, your father give you, because it's their role, but it's not the role of the nurse. You don't praise as you praise a dog. Good boy, and give a cookie to a treat to the dog if they behave. Okay. Okay. And the same, very similar praising is the reassurance. The reassurance. The most therapeutic situation is when you help the client to solve his or her problem by themselves. And this is what you are doing with reflection, when you assist the client to clarify the meaning of what the client is saying. So uh, the client, you notice that the client is sad and say something that, okay, life is unfair. Okay, life is unfair. Okay, so what you tell the client, no, life is not unfair. You need to consider that what you have is going to be cured, and you can go back to the normal life, and you have a beautiful life, and you are a professional, and you are a very smart person. Or trying to clarify what is happening in the client, not to make the client ashamed of feeling sad. Is, for example, telling uh, uh, you said that life is not good for you. Uh, um, do you think that life is not for you? For example, could be a therapeutic, okay, statement. Why? Because when you repeat not exactly, similarly, what the client said, okay, when you are like a mirror that reflects in the client what the client said, the client is going to do what? Is going to speak up. Is going to speak up. And when the client start speaking up, because this statement, okay, this reflection that you gave to the client need to put in order his or her thoughts. Yes. And then while the client is speaking up, you don't give false reassurance. You don't give advice. You don't become judgmental. You only are assessing what the client is experiencing, and you are allowing the client to speak up and to drain what is inside. And this is the basic of the therapeutic communication. You don't give advice. You don't give, in those situations, in psychotherapeutic communication, you don't give advice. You don't give reassurance. You don't give, because usually it's false reassurance. You don't treat the client like training a dog, but simply what you do, okay, is to provide open-ended questions that make the patient speak up, and speak out what is inside, and you are an attentive listener, of what the client is saying. You are, non-judgmental, attentive, and this way you can make an assessment of what the client is having, the problem that is having the client, and the clients can speak out. Remember that we are nurses, we are not psychologists, okay? And I don't know, I'm pretty sure that you know how to answer therapeutic communication questions. But notice that the good answer, the therapeutic communications, are this kind of situations in which the nurse is not patronizing or telling the client what the client must be doing. Is when the nurse guides or favors the own client, diagnosing his or her own problems and finding the solution to their clients. That's why the best option here is C as in cat. Assist the client to clarify the meaning of what the client has said. It is therapeutic. The others, the false reassurance, that advising when it's not requested, and being sympathetic. Praise is being sympathetic, not empathetic, are definitively not therapeutic. And this is, as I always been, insisting, this is a little knowledge and a lot of art, the art of the communication. That's why nursing is science and art. Okay, and it is a very strong topic in NCLEX. How you answer, okay, how you do therapeutic communication. And for my point of view, the best way of practicing therapeutic communication is practicing questions. After we study what is false reassurance, and don't give advice, unnecessary advice, don't non-requested advice, and etc., etc. I don't know if you agree with me, but this is what I can tell you about therapeutic communication. It is a very strong topic for your English. The client is admitted with a diagnosis of ulcerative colitis, an autoimmune disease that produces diarrhea with mucus and blood, and a lot of abdominal pain. A very annoying disease. Sadly, it's more common in young people, but can occur at any age. And it's interesting that the stress, even if it is an autoimmune disease, the stress, okay, exacerbates the disease. It's important to know that the treatment of the ulcerative colitis is with immune suppressors. I don't know if you watch TV, but there is a lot of commercials of ulcerative colitis in the TV. And ulcerative colitis and Crohn's disease have in common, okay, the GI and the fact that they're autoimmune. So a lot of commercial with Enbrel, etanercept, and Humira, the adalimumab, okay, or as the immune suppressors used for these conditions. Remember that ulcerative colitis, the same as Crohn's disease, increases the risk of colon cancer even in young people. And don't forget that clients with ulcerative colitis should not take antidiarrheal, including opioids that produce constipation, because can produce something very bad called toxic megacolon that requires colectomy, so removal of the colon. Those are the most important topics of content that you need to know about ulcerative colitis. Also, of course, they can ask you what kind of diet you provide to this client. Of course, diet without fiber, they have diarrhea. Diet without milk and dairy because they have lactose intolerance. And of course, need to be a diet high in protein and calories to recover the weight loss and the malnutrition that those clients tend to have. Okay, but this is it is not about this topic. It's just a brief review of ulcerative colitis based on what I think is tested. But this question says, which lab value should the nurse be sure to check? Remember that the main symptom of ulcerative colitis is diarrhea. So it could apply to any client with diarrhea, but also it is an inflammatory disease. That there is inflammation because the antibodies, the wrong antibodies, okay, are producing an inflammation and ulceration in the walls of the colon. Okay, so and the diarrhea is with mucus and blood. So once I refresh in your mind what is ulcerative colitis, so notice that to answer question, you need to have content. You need to have a content review before going to the anchors because we forget a lot. Okay, tell me, hematocrit and hemoglobin is important.
Yes, because
Yes.
Yes,
the
because they are
patient's
bleeding
bleeding.
and they
Yes.
develop anemia. Creatinine. Do you think that the creatinine could be affected in a client with diarrhea?
Not really.
No.
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 What about if the client dehydrate?
Yes.
The,
Then yes.
Yes.
the dehydration, the fluid volume deficit, the hypovolemia can produce acute renal failure, pre-renal acute renal failure. Yes, yes. Okay, so it depends, of course, if the client is dehydrated or not, but a client with diarrhea can dehydrate. Could be yes, could be yes. Okay, so even if the ulcerative colitis doesn't affect directly to the kidneys, okay, the diarrhea can produce dehydration. Okay, the client with ulcerative colitis can have 20, 25 bowel movement per day perfectly. Is it possible that those clients can have, as consequence of the diarrhea, acute renal failure? Yes. Do you need to monitor in client with dehydration the renal function? Yes. Okay, so I say that yes, for that rationale, for that reason. T3 and T4, what do you
No.
think?
No.
Definitively no. There is not any possible
No.
relation between diarrhea and this autoimmune disease with the thyroid function. So we rule out this. ESR, erythrocyte sedimentation rate. What you know
Yes.
about this?
Yes.
Yes.
It
Yes.
is a test
Inflammatory.
of
Yes.
inflammation. It's a
Yeah.
test of inflammation. When the disease has a exacerbation, when the disease has a flares up, will be increased. When the disease is responding to the immunosuppressive therapy, will be decreased. So absolutely yes. White blood cell count.
Yes.
There are
Yes.
ulcers
Yes.
in the
Yes.
walls of the intestine and there is inflammation, also are elevated. What about albumin?
I would say yes because
Why
Yes.
you're
yes? Why
excreting it
yes?
because you're excreting it through the feces when you have
To check if
feces.
there's
Malnutrition.
No. Remember that albumin is only excreted abnormally in the urine in the nephrotic syndrome. It's not necessarily excreted in the feces, but albumin also reflects the state of nutrition of the client. And the client with Crohn's disease and ulcerative colitis the clients have problems of nutrition. They have malnutrition, especially proteic malnutrition, because they are having a disease of the GI system that inhibit the digestion and the absorption. They have malabsorption, they are sick, and they are suffering of malnutrition with frequency. Absolutely yes, but it's because the albumin should be low because malnutrition. By the way, you need to know that albumin and pre-albumin are the best blood tests to evaluate the nutritional state or condition of a client. So that's my point of view of the answer of this question. With the exception of the theater, for all the rest are pertinent. A ver si lo puedo aumentar un poquito. A 29-year-old client admitted this morning for induction of labor, so obviously female. She is gravid at 2, para 1. Had an uncomplicated spontaneous vaginal birth 3 years ago of a 7 pounds 4 ounces infant. Client has no outstanding medical, social, or surgical history. Plan is to induce labor using oxytocin. Okay, so they don't say the gestational age, but suppose that is a term. I assume that is a term. Nurse notes. 6. Client arrived to unit ambulatory and stable. Verbalizers is here for induction of labor due to gestational age. Electronic fetal monitor applied. Fetal heart rate 142, which is normal. Abdomen gravid and soft to palpation. Denies having contractions, vaginal bleeding, or rupture of membranes. IV infusion of dextrose 5% in lactated ranges at 125 milliliters per hour. Initiated sterile vaginal examination performed. Cervix is 2 centimeters dilated. 50% effaced. I don't know why, if the client is not having contraction, but well, is the scenario. We dance with the music that they are playing. Soft and anterior. Station -1. You need to know that a station -1 is a high presentation that is not yet soon to be delivered. All those terms need to be known by you. You need to know what is a station. You need to know what is effacement. You need to know what is dilation. Okay, all those terms need to be used. If you notice that those terms are not well known by you, yet we need to do a content review. So I'm just, throwing, okay, indirects, okay, for the people that are, needing content review. Fetal heart rate, 140 to 145, which is good. Moderate variability. Variability is good, is reassurant. Accelerations present. Accelerations are okay, are reassurant. It's another content that you need to know. Rare contraction observed on electronic fetal monitor. Oh, see, there are some contractions. Oxytocin initiated at 1 micro units per minute per secondary infusion in lowest port of primary line. At 9, oxytocin or oxytocin is this the correct name, infusion at 11 micro units per minute. Okay, so they have been increasing dose response, okay, the dose of the oxytocin from 1 micro units per minute to 11 micro units per minute. Category 3, fetal heart rate tracing observed. So you need to know that the category 3 fetal heart rate, okay, tracing is when late decelerations or variable deceleration appears. Okay, it is a terminology that is accepted. I really let me go to my PowerPoints to show you this. B, B. Um, okay. They categorize the fetal heart rate in 3 categories. Category 1 is normal with variability and acceleration like when she arrived. Category 2 is indeterminate when they don't know what is happening. It's not important for test purposes for us. Category 3 is very important because it's abnormal. Is when there is late or variable deceleration or sinusoidal. This is a sinusoidal, okay, pattern or a fetal bradycardia. So you need to know that category 3 is bad, is abnormal. So I don't know. This is the tendency that they have now in, ¿cómo se llama? In OB to classify the fetal heart rate rhythm during labor to decide if it is okay category 1 or category 3 that is very bad and requires intervention. The category 2 is indeterminate, they need to be observed because they have no clear situation. Me deja esto abierto por si vuelvo otra vez a necesitarlo. Ya va. Okay. So what I'm learning here that maybe I didn't know that category 3 is the classification of the fetal heart rate when there is late deceleration, when the baby is having problem. Okay, having problem. Okay, this is category 3 fetal heart rate tracing observed when they increase the oxytocin 3 hours after being admitted. The vital sign of the mother is of course is normal temperature, heart rate is normal, respiration is normal, blood pressure is normal. So now that we know what meant category 3, you need to decide the following intervention if it is anticipated or it is non-essential or it is, oh Lord, or it is contraindicated. Okay, help me. Increase the oxytocin infusion to 13 milliunits per minute. Is anticipated, non-essential, or contraindicated?
Contraindicated.
Contraindicated. This drip of oxytocin should be discontinued. Why? Because the baby is presented late deceleration, a severe manifestation in which you don't want more contraction. Place client in side lying position. Let's assume that they say left lateral. Yes or not? Anticipated or not?
Anticipated.
Is correct. Is correct. Initiate a bolus of primary IV fluid. So trying to increase the circulation, passing the IV fluid more rapid. Okay, what you heard about that? You never heard about that. I never heard about that. It is done if the client, the mother, has hypotension or is bleeding or something like this. But if the mother is not hypotensive, is not any evidence of fluid volume deficit, I could say is non-essential. It's not contraindicated, it's not going to harm, okay, passing more liquid. But let's see that is non-essential. Why? Because there is not any evidence there that the mother is hypovolemic and is required to pass liquid fast. Apply oxygen at 10 liters per minute via venturi mask. Yes or not? Yes.
No.
Why not?
Oh, yes? Oh,
Yes.
sorry.
Is not included in late deceleration to administer oxygen via
Yeah.
mask to the mother. Yes or not?
Yes. Yes.
You remember that the
Yes, yes.
acronym that is stop.
Yeah.
Stop. Okay, stop. So the first is to stop the pitocin. Turn, voltear, turn the client to the left lateral. Administer oxygen, okay, through mask, okay, at high rate to oxygenate the baby and call the physician. Those are the intervention in late deceleration, which is the same as stage 3. Okay, so don't say I'm sorry. We are here all week. Are here trying to learn something to see if we pass this NCLEX. Yes. So
Prof,
speak up. Okay. Yes.
sorry.
Yes, sir. Yes.
Can you repeat the acronym, the O and the P?
Can you say again?
What you were saying about the acronym, can you repeat that, please?
I was saying about the
Stop.
It's
the
about
the acronym, the
Yeah.
acronym. Oh, yeah. Está bien, está bien, está bien. Sorry. I'm a little deaf, my friend. STOP is an acronym to remember the sequence of interventions in case of late deceleration. So it's very useful because first you stop the oxytocin. Why? Because in this moment, the placental is expressing insufficiency and you don't want uterine contraction because it's going to make the situation worse. Those late deceleration requires, pulling the baby out either as a C-section or forceps if the baby is low. The T is turn, turn the client to the left lateral. Why? Because in this position, the inferior vena cava, the mother's inferior vena cava, is not compressed by the uterus, and the blood return increases. O is oxygen, should be administered through mask, not through nasal cannula, through mask, okay? Venturi or non-rebreather, and at high flow, 8 liters per minute, oxygen. And the P is called the physician because this physician needs to pull the baby out. When there is late deceleration, the baby needs to be taken out as soon as possible because it's at risk of dying. Okay, and the physician will decide how this is taking the baby out: C-section, emergency section, or forceps if the baby is already, almost coming out. With forceps, is going to be pulled out. So this is the acronym. Okay, the acronym STOP. Okay, so oxygen is okay. So I convince you. Perform sterile vaginal examination. Okay, in this moment, this is not going to help the client, but it's not going to harm the client. In this moment, the problem is not is not the it's not the mother. When I say the client is the mother. In this moment, the problem is not the mother. It's not how much the cervix has been dilated. In this moment is that the baby is having late deceleration. The baby is at risk of dying. The vaginal examination is not going to help at all. I mark this as non-essential. It's not going to harm, like for example in placenta previa that is harming, okay, the client. But in this case, okay, it is. The Bishop score is an scoring that is evaluate how ready is the cervix of the uterus to be dilated. It's nothing to do here. Is non-essential because it has the same meaning of the vaginal examination. And then says here, perform an amniotomy. Amniotomy, you know that there is a membrane, the amniotic membrane, that is containing the liquid, the amniotic liquid, and the fetus, that is here, okay? Fetus are here. And here is the cervix that is partially dilated in this woman, and the vagina. Amniotomy is that the doctor or the midwife introduces a stick, okay, a stick with a hook in the vagina. This stick has a hook. Okay, to make the hook red like this, and then you break the membranes, and then you are going to have the flush of amniotic fluid, and the head will engage in the cervix and the bones, and this is done to accelerate the labor and accelerate the birth, but it is contraindicated in this case. It's contraindicated because it's going to make, okay, the situation worst. Okay, if you break the membranes and then the liquid is going to be expelled, is going to make the situation definitively worse. So it's contraindicated. There is no need reason for breaking the membrane in this moment. This baby need to be born through C-section because it is an early labor. It's an early labor, and and there is no chance of having the baby through vaginal via. So that's why breaking the membrane is going even to contaminate the endometrium of the woman, and is not a good a good recommendation. A client has a serum glucose of 385, so have a decompensated diabetes. Which of these verbal orders should be a priority for the nurse to question? Okay, question is to object, is to disagree, no? And call back the healthcare provider for a revision. Repeat glycosylated hemoglobin in 4 weeks. IV fluids, 0.9 normal saline, 125 milliliters per hour. Document peripheral glucose sticks every 4 hours. Insulin NPH, 20 units IV push over 10 minutes. What of these 4 questions you object or question?
D as in David.
Insulin,
The
MPH.
D as in David, because insulin NPH cannot be given IV, because you know that this insulin has a powder. You see that powder, that's why it's cloudy. And now those powders injected IV is going to produce pulmonary embolism and respiratory distress, etc. So it's contraindicated administer NPH IV. Okay, this is an easy one. The nurse must remove a fecal impaction of a 75 years old client. It's a non-nice, okay, intervention that sometimes nurses need to do. During the procedure, the nurse should remember what critical information. Family members should be taught the procedure. Cardiac dysrhythmia can result during the procedure. Increased dietary fiber and fluids can minimize such problems. The procedure is to be done prior to the bath. What is the priority of those four of the four statements that are correct? Is what's saying?
B?
B as in boy.
Yeah.
Yes, B as in boy. It's true. What kind of these arrhythmias tends to produce the digital rectal manipulation? Anybody knows?
Tachycardia?
Bradycardia, the opposite. Bradycardia. Bradycardias. When you manipulate with the finger the rectum, or even giving an enema, or when you introduce a Foley in the urinary bladder, especially when the bladder is too full, yeah, or when you suction a tracheostomy, you enter in the trachea with a catheter and you are suctioning, you are touching the trachea with a catheter. Or when you are introducing a nasogastric tube and you induce a strong gag reflex, a strong, nausea gag reflex in the client, you are stimulating a nerve called vagus nerve. The vagus nerve is the 10th cranial nerve, originates in the brainstem and lives, okay, in the cranium, and descends all the way around, down, okay, all the way down until the pelvis, until the genitals, until the rectum, yeah. and is the nerve that is innervating the vocal cords, the salivary glands, the heart, the bronchi, the stomach, the intestine, the urinary bladder, a lot of organs. Because all those viscera or organs, okay, are controlled by the parasympathetic nervous system. The vagus nerve represents the parasympathetic nervous system. The vagus nerve, when it's stimulated, is called vagal maneuvers. Vagal maneuvers, okay? And the vagal maneuvers include, producing the gag reflex, inducing the gag reflex, like touching the throat, or it could be asking the client to bear down to do Valsalva, or could be a digital rectal examination, or could be administer a cold water enema. There are a lot of vagal maneuvers. The only one that nurses do is Valsalva, asking the clients to bear down or cough. Okay, but those are all vagal maneuvers. Can trigger a bradycardia and hypotension. The client becomes pale, nauseated, cold, and sweaty while you are doing the procedure. Suctioning in the trachea, administer an enema, doing a fecal disimpaction, draining a urinary retention, then your client, because what you are doing can become, can crash. And this is what is said in the jargon of the field, of nursing. Or the patient is crashing. Okay, you say if the patient is driving, no, the patient is crashing. Okay, it is an English language frequent term. And the consequence, the cause of this crashing, of this decompensation, acute decompensation of the client starts saying, I feel bad, nurse, I'm feeling very bad, I'm feeling very dizzy, I have nausea, okay, I feel that I'm passing out. It is because a vasovagal reaction and a stimulation of the vagus nerve by those maneuvers. And the cardiac arrhythmia that you expect is bradycardia instead of tachycardia. Okay, so just in case, I think that this little comment that I just gave to you is going to be useful not only in case of questions, it's going to be useful in the real life when you start practicing nursing, because it will happen a lot to you. You are suctioning a client because the client is stable and the client needs suction because it's full of flames. And when you start suctioning the client is going to crash, become very pale, and it has a monitor, the heart rate is 40, 45, and the blood pressure drops, and you freak out because you don't know what is happening. What is happening is a vasovagal reaction. What you do, stop what you are doing. Stop what you are doing. That's it. This is what you need to do. And elevate the legs of the client. Okay, because this will elevate the blood return, will elevate the blood pressure. And of course, if it is possible, like a patient that you are suctioning, okay, administer oxygen. Okay, administer oxygen. Anticipate that it can happen in all these procedures. Okay, and don't freak out. Usually the patient is not going to die. Becomes very, very, very ugly. Okay, it's very ugly, the reaction, but don't freak out. Okay, just stop what you're doing, stop stimulating the vagus nerve, elevate the legs, give oxygen, and wait 5-10 minutes, and it will pass out. Reassure the client. Okay, reassure the client. It's not false reassurance, it's a good reassurance. Okay, okay. While discussing issues with colleagues on the unit, the novice nurse seemed surprised when the other nurses states that the manager the manager assumes the responsibility of all decision without the staff input. What is the best description of the nurse manager management style? Ultra liberal or communicative, laissez-faire or permissive, autocratic or authoritarian, participative or democratic. What
Sí.
color? What color?
Sí.
What color is the white horse of Napoleon? Okay, so it's a question of. Well, but by the way, it is very common in English. The type of, okay, and the two that more frequent appears is the autocratic and the laissez-faire. Okay, the two varieties or abnormals or varieties of management that more commonly present in English are these two. Okay, so be aware of that. But generally, it's a very easy questions, as I said. Okay, the Lisa first too liberal is too permissive. Is each time you are adult and you have your license, the one that is going to lose your license is yourself. So try to behave. I'm not going to supervise you. It is a laissez-faire. I I associate what with the lazy. Laissez-faire, lazy. Okay, to remember sometime. Okay, is useful. Mm. The nurse is evaluating a 60-year-old male client admitted for chest pressure and the following EKG. So let's analyze the EKG. I have P wave before each QRS. Yes, so I have apparently a normal sinus rhythm. I have a frequency of 1, 2, 3, and less than 4 big boxes. So the frequency is normal. So I have a normal rhythm. The rhythm is normal. But let's see if there is something in the morphology, in the shape of the waves that a nurse could identify. And I'm noticing that this is the baseline. This is the baseline. And the ST segment, which is this part, is elevated. So I'm noticing that it's a persistent ST elevation. And this is very characteristic of the myocardial infarction. So probably this client is having an ST elevation, probably, very probably, ST elevation myocardial infarction. Are other conditions that could mimic this? Yes. It's not exclusive of myocardial infarction, but 99% that it is a myocardial infarction, especially if the client is 60-year-old, is male, and has chest pressure. Okay, so it is very probable that it's a myocardial infarction. Elevation of which of the following tests is the most reliable for the confirmation of the diagnosis of myocardial necrosis? Elevated
Troponin.
C-reactive troponin. Troponin is the answer.
Professor, didn't a change similar to this one, it's related to potassium as well?
Okay. The potassium, when it's low, will produce a depression of the ST segment, no elevation. I have a nice mnemonic. At least I found that nice because I'm very visual person, as you have noticed. So just a moment to see if I can find this potassium. ¿Dónde está esto? Electrolytes, yes. Electrolytes. Just a moment, guys. Okay, here coming. Okay, electrolytes. I found this mnemonics. I found wonderful. So what happens in hypokalemia? So look at this. The ST segment is depressed and this hand is pushing down the ST segment. But you know that when you have like a, I don't know, like a mattress or a air balloon, something like this that is soft, when you push down, the other part goes up, protrudes. And this is the U wave. So what happens with the ST segment and the T wave in hypokalemia is going to be down, is going to be depressed. So the ST segment has depression, and the T wave inverts. But then there is, as a compensation, a protrusion, okay? Protrudes or bulge would be the most common word, bulging of the remaining stuff. That is the U wave, that is a positive wave. So I found this very visual for me, that I'm a very visual person. Yes. And it's for your memorization. Remember that when the potassium is low, you can push down because it's low. No? Low potassium, push down the ST segment and the T wave, and as a compensation, you will have a bulging of the U wave. Yes? So it is the stuff. But in hyperkalemia, you need to pull up. In high potassium is up, not pull up. So you pinch, you take the T wave and you pull the T wave up, as you're seeing here, because the potassium is high, and then you have a tall and peaked T wave. You understand? Also, the QRS will widen and the PR segment will prolong and the P wave will flatten. Okay, will flatten. Do you like it? Okay, so it's very useful. So don't confuse potassium stuff with this MI manifestation. Okay. Troponin. This is a common question also. Troponin is the one that confirms the MI. If there is necrosis, troponin elevates. If there is angina and there is not myocardial infarction, troponin doesn't elevate. Okay, but don't forget that troponin takes time in elevation, in elevating. Yes. So troponin takes 1, 2, 3, even 4 hours to elevate. So which test can tell first that the patient has MI? The EKG. And this is an Nclex question. You have a client arriving and you suspect myocardial infarction. Which test you do first? EKG, troponin, CKMB, and I think was white blood cells. And the answer was EKG. Why you do EKG before troponin? Because the patient is just arriving. It's the first test to be done. If the client is having MI, the most probable, let's see, 98, 99%, is that you find significant alterations in the EKG. But the troponin will take some time in elevating. That's why you do first the EKG and second the troponin. Is comments. Don't forget that the troponin stays elevated a lot of days, 7, 10 days. And it's useful to do retrospective diagnose of MI when the client didn't consult immediately when they have the chest pain. The nurse is performing a pre-kindergarten physical on a 4-year-old child, 4 years, and will administer a series of scheduled vaccines, including DTaP, IPV, MMR for years, and VAR. What information, Varicela, no? What information does the nurse need to know about this vaccination cellular apply? Either the deltoid muscle of the arm or the anterolateral thigh muscle can be used. It is true. Okay, in a preschool, you can use still you can use the thigh, the vastus lateralis. Even in adults, I used to inject myself in the vastus lateralis because it's the one that I feel less. Okay, the only problem that it hurts a little when you walk. A 20 gauge needle is used to administer the varicella vaccine intramuscularly. What you know about this?
That's a big one. This is for the blood transfusion.
Okay, the information that I have in the varicella vaccine is subcutaneous and not intramuscular. And generally, the live viral vaccines are given subcutaneous. And it's not intramuscular. So in that case, we will use a more a finer gauge. So a 20, 26, okay, and 26, 25, and subcutaneous. So that's why I should not be using this, because the information that I have is that the live viral vaccines are given subcutaneous. A 5/8 inch, so a short needle length, is often used for subcutaneous injection. It is true. The vaccines contain the preservative thimerosal. What do you know about this? Okay, in many long time ago, decades ago, the MMR
It's allergy.
contain,
Isn't that an antiseptic that was used a long time ago? Like it was orange or something like that?
it was not orange, okay? The orange
Okay.
color, orange color is a color that produces allergy reaction, etc.
Yeah.
Is a preservative of the vaccines that was used long time ago and was used in the MMR. And some patients develop reactions to this preservative and has been eliminated of the vaccine like 30 years ago. The some people developed a false information that because the presence of dimethyl, the children develop autism when receive those vaccines. And you need to know as a nurse first that the vaccines now they don't have this preservative. And second, there is not any evidence that this dimethyl that produce allergic reactions and then don't have any relation with autism. So the answer is no. But we need to know this story. This is story of the vaccines. Multiple immunizations should be administered a minimum of 1 inch apart. It is correct. Always the shot should be given 1 inch apart, any shot in any part of the body, adults or children. And the vaccines all contain weakened live virus. It's not true, because the DTaP has no live virus, IPV has no virus, MMR and varicella are the only one that contains weakened live virus. So it is just a review of vaccine. Today, one student uh, told me about a question that she had in her English. They say, the nurse is administering vaccines. Which of these following 4 clients can receive the varicella vaccine? Can be administered the varicella vaccine. And then the options were A, patient with Hodgkin lymphoma, Hodgkin lymphoma in treatment. Decía only in treatment. B, 14 weeks gestation woman. C, client with active TB in treatment. And D, client allergic to gelatin. To yellow. Decía sí, gelatin o yellow. Okay, gelatin. What you answer? If you have this question, because it's an English question.
So the B is not
Okay,
an option.
so
A and B, no.
A and B are no option because A is immune suppressed because the treatment of the Hodgkin include prednisone and chemotherapy, and B because it's pregnant. So now you have those two. So good strategy, you are doing the correct. The only content that you need to know is that the MMR MMR, and the varicella produce allergy reaction, a patient that is allergic to gelatin, neomycin, and egg. Okay, so it rule out the last one. Entonces, the only that can receive the varicella vaccine is a person with tuberculosis in treatment for tuberculosis that lasts almost a year, but has nothing to do with the vaccine of varicella. The client with tuberculosis are not immune suppressed and have not any contraindication of receiving this vaccine. The answer was C. Client with active tuberculosis treated for his or her tuberculosis. Okay, so have this knowledge. But at the same time, I need to discuss something with you. Before, nurses thought that clients allergic to egg could not receive the flu vaccine before, long time ago. But since 3 years ago, the Center for Disease Control, which is the one that follows the NCLEX, yes, the NCLEX, said that there is no contraindication to administer the flu vaccine in people allergic to egg. So egg allergy is not a problem in clients to receive the flu influenza vaccine. Okay, so it is another common question in English that is already in English. Okay, in English, the question that said the client that has contraindication to receive the flu vaccine is somebody that had previous Guillain-Barré secondary to flu. This is the one that cannot receive the flu vaccine. Okay, just in case any one of you don't know that, you need to know that it's in English and is CDC insists a lot. Okay, understood? I assume that if you are not asking me question because you understand what I'm saying.
Yes, thank you, Professor.
Okay, very good. The nurse is teaching a client about a new prescription of nortriptyline. Nortriptyline sounds like amitriptyline. And those are a group of antidepressants, very old, very old, okay, called tricyclic antidepressant. Those antidepressants produce a lot of sedation, a lot of sleepiness. So it should be given at night. It's a common question of this medication. And also have potent, very potent anticholinergic activity, atropine similar activity. So what is the action of the atropine? Dilate the pupils, are contraindicating glaucoma, dry the mouth. So you are going to have a client sucking hard candy, constipation, urinary retention in all men. What else? ¿Qué más produce la atropina? Tachycardia and cardiac dysrhythmias. And blocks the anticholinergic, blocks the sweating. Okay, you block the sweating. Okay, so let's see. What information should the nurse emphasize? What is the important? Episode of diarrhea can be expected. No, constipation is expected. The medication must be stored in the refrigerator. No, niñas, it's a tablet. It's a tablet that can be anywhere. Could be a fresh place, but not in refrigerator. It's not a shot that are they usually kept in the refrigerator. Must be taken in before going to bed. This is correct. Symptoms relief occurs in few days. No, those antidepressants take weeks or months in noticing the improvement of the mood. So an easy question. A brief review of the pharmacology, this subject that you love a lot, of tricyclic antidepressants. And the last, a nurse is assessing a woman in early labor. When positioning her for a vaginal exam, the client reports feeling dizzy and nauseous. It is because when the client was placed recumbent in the examination, okay, position, okay, examination position, the uterus start compressing the inferior vena cava that brings the
Professor,
blood.
that is the blood pressure is going down, right?
Exactly.
The
Is
syndrome.
the inferior vena cava compression syndrome, that the uterus compress the vena cava against the spine, the column, and that's why the compression of the inferior vena cava decreases the blood return, and then the blood pressure drops.
Can
Okay,
you turn her to the left side?
so let's say, all very simple. Find a wedge, a pillow. Find a pillow and put the pillow in the right cheek, the right buttock. Okay, and then it produced a slight displacement of the uterus away from the infravena cava, and this, okay, it will. But the answer of this question is turn the client to the left side. Okay, okay, is the inferior vena cava compression syndrome. Okay, that occurs in this position. That's why an Nclex question is what should do the circulating nerves when position the client that is going to have a C-section, a cesarean section. What should be done? What should be done by these nurse is place a wedge in the right buttock, okay, in the right side to slightly displace the uterus to the left and decompress the inferior vena cava. Okay, 30. Okay, this is what I have for you today. Do you have any questions? Are you okay?
No questions. Thank you so much.
Okay, so remember my recommendation that if you find any area that you feel that you are weak and you want to review content, okay, you can tell me and we'll review that. Okay, guys, see you next time. God bless you.
Have a good night,
Thank
Professor.
Thank you.
Thank you, boss.